Hi everyone, my name is Kev Tang and I'm one of the doctors in South Yorkshire in the UK. Thanks for joining us this evening. I'm sure we'll have seen some of you before, but if not, then welcome to the next webinar in this Minor Bleach Radiology series. So over November, December and January, we are aiming to cover pretty much all the imaging modalities that doctors and healthcare professionals come across in the hospital and how to interpret them. So last week, Dr. DeBoer took us through hand and wrist x-rays. So today we'll be continuing the MSK section of the series. So Dr. Joe Kang will take us through a structured approach to knee, ankle and foot plane films, which are some of the films that junior doctors, including myself, often find more difficult to interpret. He'll go through a logical approach to interpreting all these plane films and we'll discuss some cases with us. So we will just crack on with it. So Joe, I'll hand over to you.
Thanks, Kev. Hi everyone, my name's Joe. I'm a radiology registrar here in Sheffield. So for those of you who are not in the UK, Sheffield is here. It's in Yorkshire, and it's known for two things really. It used to be very big in the steel industry in the industrial era in the UK, and also it's next to the Peak District, which is a very nice piece of countryside. So anyway, what we're going to talk about today is imaging of the lower limb, so from the knee down to the foot, basically. And I'll go over a few key principles. Then we'll cover a bit of the basic anatomy, but not too much. But I will talk about the standard X-ray views. So when you ask the radiology department to perform a foot on the X-rays, what combination of X-rays will they give you to look at? And then I'll try and go through the principles and the structured approach and how you should be looking at these with cases and examples to illustrate. So I'll try and keep it as interactive as possible. I've got my eye on the chat, so if you have any questions, just type a message and I'll try and keep my eye out for that. So starting out with some basic principles. So the most important thing that I want you to take away from this talk is that you need two views to exclude a fracture. As you can see here, there's a slightly silly photo of a lion holding a cub, and on the left here, it looks like the lion has swallowed the head of its cub, but with an orthogonal, so you rotate the view 90 degrees, and you actually get a better idea of what's going on. So this is the same with fractures. So from one angle, something could look normal, but when you rotate it and look at it from another side, it could look entirely abnormal. And lots of fractures can only be seen on one of the X-rays of a series you're given. So you need to look at all of them to exclude a fracture, basically. So once you're happy with the views, which are satisfactory, you need to look at the alignment of the bones. So clearly this is abnormal. So this is a lateral ankle X-ray, and this is the distal tibia. So the normal alignment is illustrated by this line here. So this is clearly dislocated. So you're happy with the views, you've looked at the alignment of the bones, and then you need to move on and look at the cortex. So the cortex is sort of the outline of the bone. I don't know if you can see my laser pointer. So every bone has a slightly denser, so denser meaning whiter outline to it, which is the cortex. And when there's an acute fracture, the cortex will be disrupted. So as an example, if I point out this abnormality here, there's a sort of a rounded lesion here behind the talus, and there's another rounded lesion here which is also behind the talus. So guys, this is number one, this is number two. Which one do you think is a fracture and which one is normal? If you want to type your answers into the box. Good. Some people have. Someone said two. Someone said both. See, some people have said one as well. Okay. So most people have said 2. Can someone offer an explanation as to why it's 2? Oh, right, okay. Yeah, we've got a few answers in. This is very good. So, so what have we said? So yes, someone has said number 1 is os trigonum. Very good. So yeah, this isn't a fracture. This is a normal variant. There's a, it's kind of a developmental thing, but there's commonly a fragment of normal bone in that position. It's called the os trigonum. But this, number 2, is an avulsion fracture. And I think someone else has said the reason it's an avulsion fracture is because the reason you can tell is because there's disruption of the cortex here. Whereas you see here, there's a nice smooth outline to the back of the talus. Here there isn't. It looks kind of ill-defined, and the actual fragment itself looks quite ill-defined as well. Whereas here, in the normal variant, the outline of the fragment is very well corticated, so that's unlikely to be a fracture. This does involve knowing sort of the common places for these accessory bones, and I think that just comes with a bit of experience. But the os trigonum, which is posterior to the talus, is a very common location in the foot. So if you look at enough ankle X-rays, you'll see lots of these. The other thing that can also be a sign is I'll talk about it later, but the soft tissue swelling as well. So if you see here, the soft tissue is sort of behind the ankle joint. It's quite edematous, a bit whiter than here, whereas this is nice and dark. You see the subcutaneous fat and the Achilles tendon is all quite well defined. But here, the tendon is quite ill-defined because there's lots of soft tissue swelling here. So that's kind of a secondary sign that suggests that this is more likely to be an acute fracture. Yeah, so everyone else has said, yeah, you guys already know this stuff. Right, so then the other thing I said I would move on to is look at the soft tissues. So what do you guys think of this film on the left here? What's the abnormality? Yep, exactly. So lateral malleolus fracture. This fracture is very obvious. I tried to find a more subtle example, but I couldn't find a good one. But the thing I wanted to draw your attention to for this example is if you compare, I mean, if you look at your own ankle and you palpate the lateral and medial malleolus, there's very little soft tissue there. It will feel like this side here. That's a normal amount of soft tissue to have for most people. Obviously, some people have fatter ankles than other people, but the way you can tell whether it's abnormal or not is to compare to the other side. This soft tissue is clearly swollen. This isn't. So when you look at an X-ray, you follow the cortex, you don't immediately see a fracture necessarily, but you see very prominent soft tissue swelling, then that's going to make you go back and look at the bones again. Because if there's loads of swelling, it's much more likely that there's some kind of bony injury underlying it here as well. So you can see the thickness of the soft tissue, but also, like I said in the previous example, it looks edematous and denser. So more white on the X-ray compared to the normal fat on the other side. This is particularly prominent sort of in the lower limb of the ankle because most people don't have lots of fat over their malleoli, but also I'm sure Henry talks about in his previous talk. If you look at the wrist, soft tissue swelling around the wrist is very obvious as well on X-rays. So the sort of following on from that example, what do you guys think of this X-ray? Yep. So we've got a few answers coming in. So the one person said effusion, which is spot on. So this, which is someone was also suprapatellar bursitis. So this is the knee effusion. So normally you should see the patella tendon very clearly defined, and then basically this shouldn't be edematous down here. This should look like kind of this fat density here. And I don't know if I can convince you, but there's sort of a rounded opacity here, which is displacing the patella tendon upwards. And this is because there's fluid in the suprapatellar pouch. So this isn't, so there have been a few answers saying lipohemarthrosis. So lipohemarthrosis is a type of joint effusion, but specifically referring to the fact that there's blood and fat in the joint. So this isn't necessarily a lipohemarthrosis. I'll come on to that later. But what you can say about this is this is quite a big knee effusion. So when you see a big effusion, again, like the soft tissue swelling, it's kind of a reactive thing, and it suggests there's some kind of other underlying pathology. And that could be a fracture. I'll come on to that later, but it could also be a ligamentous injury, so such as the ACL or the PCL, which you wouldn't see on a plain radiograph like this. So if a patient has a big knee effusion, no obvious fractures, then they still might be referred to orthopedics, and we might do an MRI to look at the ligaments if there's a high suspicion that there's some kind of underlying injury. So principle number 4 is look at the soft tissues. Soft tissue swelling guides you towards the area where the pathology might be. And if you see lots of effusion, lots of soft tissue swelling in the absence of other injuries, then you either need to go back and look harder, or if the patient has persisting symptoms and there's clinical suspicion or mechanism of injury is high, then they might need further investigations, such as an MRI. Right, so we'll talk about the knee X-ray. In our center, if you request a knee X-ray, you get 3 pictures. So this one on the left here is an AP view. So that's front to back. Hang on, someone said, is there a fracture of the tibia? Are you talking about this bit of irregularity here? So I think that's just, I think that's part of the insertion of the patella tendon. You can get a bit of irregularity there from tendonitis and things. I'm not sure that's an acute fracture. I think there might be a fracture in this tibial plateau, but I haven't got the AP view of this one. But I do have an example of that, so I will come on to that. So normal frontal AP view of a knee, and then an important view, which I'll explain why we need to do, is the horizontal beam lateral. So it's abbreviated to HBL. So this is a true lateral film, which means the patient is lying on the table with their leg out flat, and we rotate the beam of the X-ray to take a picture from the side. And the reason we do this is to look at knee effusions. But I've got an example of that later. And then the other view we do is the skyline view here. And the skyline view is less important in trauma. It does let you have a good look at the patella for fractures, but it's mainly used to evaluate the joint space to look for degenerative change, or if there's a patellar dislocation or something. You can't always do a skyline view like this because the patient has to bend their knee to 90 degrees. So if they've injured their knee, it might hurt too much to do this. So if there's trauma, you might just get the AP and the lateral views, and it's important to look at both. Right, what's this? There are several findings, so just shout out. Okay, we've got a few answers coming in. Okay, you guys are very good. You've all seen it. Yep. Okay. So I'll just, for those of you who haven't answered the question, I'll point at the abnormalities. So abnormality number 1 is this. So this is why we do a horizontal beam lateral view. This is something called a lipohemarthrosis. Lipo means fat, hemo means blood, and arthrosis means joint problem. So this means there's fat and blood in the joint space, and that is suggestive of a fracture that's intra-articular. So a fracture within the joint bleeds, and it bleeds into the joint space. And because the leg is flat, you see a fat fluid level. Fat is less dense than blood, so it rises to the top. Blood is denser, so it sinks to the bottom. And you get this very, very straight horizontal line that demarcates the boundary between the two. If you see this on an X-ray, there has to be a fracture. You might not, and the fracture has to be intra-articular, so within the joint. In this case, there is a very obvious intra-articular tibial plateau fracture, and there's also a fracture of the fibular head, I think. You don't always see this. Sometimes you just see the lipohemarthrosis. But if you see this, there has to be a fracture. Does that all make sense? So if you see this, you look more carefully at the tibial plateau. You look at the AP view as well, because you might see the fracture there. And if you still can't see the fracture, then the patient needs referral to orthopedics with a view to getting further imaging. We can either do a CT of this or an MR to look for a fracture. But if you see a lipohemarthrosis, there has to be a fracture. If you just see an effusion without this level in it, there might not necessarily be a fracture. Right, okay. If anyone has any questions, then just type them in and I'll keep an eye out. Right, what do you guys think about this one? Also, I'm aware that I said everything needs 2 views, but I found lots of 1 view examples to illustrate this. So I'll just wait for a few more answers. Right, okay, so we've got a few answers in. So someone said osteophytes. There are osteophytes, but that's not the primary finding. So the history is fall knee pain. Yep, tibial plateau fracture, depressed tibial plateau. Good, okay. So this is the abnormality. So this is a fracture of the lateral tibial plateau. There's a depressed fracture. So if we go back to our structured approach, so you want to follow the cortex all the way around. So this is, if we look at the medial aspect, we see this nice sharp line of the cortex. It goes all the way around. It's continuous all the way. Whereas if you try and follow this, you get to here and there's a step. So that's a fracture. And then you follow it up to the top and this looks very indistinct. So this is all a fracture fragment that's off the tibial plateau. Sometimes it's more subtle than this. And the other thing that I like to look at, so that this is quite obvious because there's a big step, big discontinuity in the cortex. Sometimes it's more subtle. So can I convince you that if you look at the normal side here, or up here, for example, there are lots of these little lines and sort of darker bits in the bone here. So this is the normal trabecular pattern of the bone. So this side is normal. Whereas if you look at the underlying bone here, it's not a regular trabecular pattern all the way down. There are sort of denser bits and normal bits in between. So this means that there's disruption to the trabecular pattern, which implies there's a fracture. So again, there's a step here, so this is obviously a fracture, but sometimes you just see a slight change in trabecular pattern, which makes you think that there is a fracture. Sorry, I don't know if my internet's not really clear. But you can always compare it to a normal side, or if they have a previous X-ray, you can see how it looked before. Or you can compare to the other leg if you're not sure. Someone said osteophytes. So yeah, these are osteophytes of the tibial spine, which is just degenerative change. And then the other thing is that there is quite a lot of soft tissue swelling around this knee as well. There's lots of edema here. Yeah, so this is a depressed tibial plateau fracture and also a fracture of the fibular head. The other thing I wanted to mention is that, at least if you're working in the UK, if the radiographers see an abnormality on an X-ray, they sometimes write red dot on it. So if you look at an X-ray and it says red dot in the corner and you don't see an abnormality, go back and have another look. I don't know if they do this in other countries, but here they like to write this if there's an obvious abnormality. Right, how about this one? So again, it's a similar history, fall, knee pain. Hang on, this question. Avulsion to the lateral epicondyle. So I think this is all a bone fragment. I'm not sure this is. Oh, do you mean up here? Yeah, I think that there could be another associated injury here. I think this is quite a bad twisting injury. So they've kind of this bit of bone has come down against this bit of bone. So there's a twisting compression injury. Right. What do you guys think about this one? Yep, exactly. I should have put this one in later on because I've told you about it. Yeah, so this is a more subtle example of a tibial plateau fracture. So again, if we go back to our approach, you want to follow the cortex around every bone. And if you follow the proximal tibia, so maybe if you get here, there's a little step and there's a little lucency. And maybe if you look here, there's a step and a little lucency. But the finding that makes you more convinced that this is definitely a fracture is that this bit of bone looks denser than normal, and there's disruption of the trabecular pattern here. Again, if you compare to the other side, there's very regular, straight trabeculae, and down here as well, but they're disrupted here. So this has to be a fracture. Even if you didn't see the defect where I'm pointing to either side, this in itself is enough to call this a fracture. Yeah, there probably is a bit of loss of medial joint space. I think maybe lateral. I think some of this is projectional. It's not a great sort of AP view that lets you see the whole joint. And there probably is a bit of degenerative change as well with the osteophytes. Right, okay, so move on to the next one. So what do you guys think about this one? Well, actually, first question, how old do you think this patient is? Yep, good, yeah. So this is, so when we talk about X-rays, you can infer the sort of the rough age of a patient from this by looking at the growth plates. If the growth plates aren't fused, then it has to be a child. And as they get older, they kind of become partially fused and then fully fused in adults. So this is a child's knee. Right. So what do you think so again, the history is always, as always, fall knee pain. Right, okay, yeah, so the abnormalities in the proximal tibia. So this is the abnormality. Oh, a few more answers coming in. Yeah, so this is an avulsion fracture of the tibial spine. So what structure attaches to this bit that's broken off? Does anyone know? Yep, exactly. So this is the ACL attaches to this tibial spine, and avulsion injuries are more common in children because their bones aren't as strong and well mineralized. So this will be an avulsion injury caused by the ACL pulling off a bit of the bone that's attached to, and you can tell it's an acute fracture because there's a lucency through here and a cortical defect. Good. So we talked about looking at the growth plates and ACL avulsion injuries. So you guys are very good. You already know this stuff. Okay. And what do you guys think about this one? Is there a head of fibular fracture? No. So I think this is growth plate irregularity. I'm not sure that's an acute fracture. I think there's partial fusion of these growth plates actually. I think they're probably slightly older, maybe a teenager. Right. Okay. What do you guys think about this one? Okay, very good. So you guys have spotted, presumably, this fragment here. Lateral aspects of the tibia is what you're saying. Lateral tibial condyle. Good. Okay. So you've seen that. Is that a bad injury? Would you send the patient home with this? Oh, someone said yes. I presume yes, it's bad. Why is it a bad injury? Right, so people have said, right, let's see what you guys have said. So check foot drop. Oh, so you're talking about perineal nerve injury. Yeah, good point. Yep. Lateral collateral ligament. Yes. So there are two things I want to illustrate with this. So I agree, there is an avulsion fracture of the lateral aspects of the tibia, and this is something called a segond fracture, S-E-G-O-N-D, and it's a very common X-ray we see in radiology exams. So this in itself isn't particularly bad, but it implies that the mechanism of injury involves some kind of high energy trauma. It suggests that other structures must be injured. So it's not just about the fracture that you see, it's about the other associated injuries. So you see there's lots of soft tissue swelling on the lateral aspect of the knee here, because this fracture is associated with medial collateral ligament injury. And not only that, my second point is there's something called satisfaction of search. So you guys have all seen this lateral, this injury on the lateral aspect of the knee, but have you looked for any of the other injuries? So when coming back to our systematic review, we follow the cortex around, and we look at the trabecular pattern, and we look at the alignment. So just because you've seen one injury, you need to carry on looking at the rest of it to make sure you haven't missed anything else. Oh, yep, someone's seen it, yeah. So tibial plateau. So similar to the previous one, there's injury to the tibial spines. There's a fracture here. So this lucency here is another fracture. So the second fracture, which is this sign, implies there's injury commonly to the lateral collateral ligaments, to the meniscus, which is in between in the joint space, and also to the anterior cruciate ligament. So just seeing this tiny bone fragment in itself is not particularly remarkable, but it implies that there are other injuries, other soft tissue injuries. So this patient will need an MRI of their knee to assess their ACL. So this is called a second fracture, SEGOND. Is there a white fracture line on tibia neck? Are you talking about this line here? Or that line here? Here, you mean? Or here. So I think this is just the outline of the fibula behind the tibia. I think that is the remnant of the growth plate. So I don't think there's, I mean, back to my first point, you want to look at the lateral view to make sure the fibula head isn't injured. But I think on this frontal view, that's just sort of overlapping between the tibia and the fibula. But yes, I agree. If that, you would want to look at this on the lateral view to make sure there isn't a fracture here. Okay, so does that all make sense? The second fracture is this here, but this implies there has to be injury, or there is very likely injury to the collateral ligaments, the cruciate ligaments, and the meniscus. And it's commonly sort of impact injuries and twisting injuries of the knee that cause this. So if people being tackled playing football, or people skiing, basically anything where your foot stops moving but your knee carries on moving, and it twists the knee. Right, okay, so I think I've got a couple more examples of knees. So actually, to recap, the principle on to illustrate here is you see one abnormality, you don't stop looking. You finish your systematic review of the rest of the bones to make sure you don't miss anything else. Right, a slightly more simple one. What do you guys think about this? Yep, good. So this is a patella fracture. See this lucent line here. I was hoping to trick you. You know, I've spent all this time talking about looking at the cortical outlines. I was hoping no one would look at the patella, but yep, you guys have all seen it. And this is also why we do the skyline view, because it's much more obvious on this view here. Yeah, so I agree actually. On this AP view, this could conceivably be a bipartite patella, which is a normal anatomical variant. It's difficult to tell because you can't really look at the cortex on this AP. The reason why I've illustrated this is because the patella is often hard to see on the AP view, whereas it's very obvious on the skyline if there's a fracture. And you can see here that this is clearly a fracture because there's no cortex here. So I think we don't always do it. If you can, yeah, I agree. This would be very painful for the patient to do. I think we probably wouldn't, if there was an obvious fracture, this would be difficult to get the knee into this position. But clearly they tolerated it, and we managed to get one. So patella fractures tend not to be particularly unstable, I don't think, because there's lots of muscle supporting them. So I think bending the knee wouldn't be particularly bad. I say I'm not an orthopedic surgeon, so I'm not Not entirely sure about that. Right, so moving down the leg. So this is pretty obvious. What do you guys think about this? Yeah, exactly. So there are communist fractures, both sort of obvious examples. Communist fractures of the tibia, fibula. Similarly here, different patient oblique fractures, distal tibia and distal fibula. So the point I wanted to illustrate is something called the polo. It's been referred to as the polo mint principle. So I don't know if you guys have had a polo mint before, but it's a round mint with a hole in it. And the idea is that if you want to break the polo mint, it's very difficult to break the polo mint in a ring just in one place. So if you break it, it always breaks in two places. And similarly, if you consider the tibia and the fibula as a system, it's connected by the proximal tibio-fibula joint up here and the distal tibio-fibula joint down here. And there's kind of a fibrous interosseous membrane in between. But basically the idea is if you have a fracture through one side of it, one side of this ring, you have to have another fracture somewhere else. Otherwise it's very, very, and that doesn't necessarily have to be a fracture through the bone, it could also be disruption of the joint. But if there's one injury to any part of this ring, you need to look for another one. So we'll come back to this and when we talk about the ankle. So so these are sort of the standard views we do for an ankle. So we do an AP, so front to back, and we do a lateral from the side. Some places will also do a dedicated mortise view to look at this space here. But where I work, these are the standard views, and you get a good view of the mortise on the AP that the radiographers do. And so that's that's what you normally get if you ask for an ankle X-ray. So talking about some of the fractures, so I presume you guys have all heard of something called the Weber classification. So the Weber classification is something that you'll have to use to describe fractures of the lateral malleolus. And this is important because the Weber classification affects the classification of lateral malleolus fractures affects how they're managed. And certain types can be managed conservatively, and certain types are unstable and need surgery. And broadly speaking, it's all about the location of the fracture relative to the syndesmosis, which is this kind of fibrous structure that connects the distal tibia to the distal fibula. And the classification is A, B, and C. Confusingly, A is below rather than above, but so A is below the level of the syndesmosis, B is at the level of the syndesmosis, and C is anything above. So A, again, I'm not from a surgical background, but broadly speaking, A can often be managed conservatively because they're stable. B sometimes requires surgery, and C is usually unstable and needs something doing about it. So what do you think of this fracture or this X-ray? Yep, good. So there's Weber A, very clear here. And back to my point about soft tissue swelling, there's lots of soft tissue swelling here. So even if this was more subtle, this will draw your attention to it. What about this one? Yep, very good. And finally, probably no points for this either. Yep, great. Right, what do we think about these two X-rays? Oh, yep, I like how someone said the views are inadequate. Yeah, I agree. These views probably are inadequate, but I borrowed this case from Radiopedia, so it's not my fault. Yeah, so this is something called a meson nerve fracture, but this is about my point about the polo mint, the idea that you have to have two fractures here. So there's a fracture of the proximal fibula here, which is quite obvious, but you see this. So say you saw this at the bottom of a knee X-ray, then what you need to do is ask for the ankle to be imaged as well, so you can look for the second injury. And similarly, so when you look at the ankle, which this is admittedly a slightly inadequate view of the ankle, you see an injury to the lateral malleolus and widening of the tibio-talar, widening of the ankle mortise. So this comes back to the principle of if you see one injury on one end of this polo mint, you need to look at the other side. Can you guys all hear and see me, right? I think people are still answering questions. Right, okay. Yeah, so to recap, this is a meson nerve fracture. So there's two injuries, proximal fibula and medial malleolus, an ankle. So the injury at the ankle doesn't have to be medial malleolus. It can be injury to the tibio-fibular joints, so just widening of this space here. It could be an injury to the medial malleolus, or it could be an injury to both malleoli. But it's a combination of a fracture up here and some kind of widening of this space that manifests as the second injury. So this is just another example. So again, a slightly suboptimal view of a proximal fibular fracture. And see here, there's no obvious bone injury, but this space in the ankle mortise is abnormal. So normally when you look at the mortise view, this side should be the same as this side. It should be an equal joint space all the way around. But this is clearly widened here and narrowed here. And this space is also abnormally widened. So this is all ligamentous injury. You don't have to have a fracture with the meson nerves. You can have one fracture up here and all ligamentous injury down in the ankle. And again, this is another example of an unstable ankle injury. So this is fractures through both the medial and the lateral malleoli. And there's clearly widening of the ankle mortise and lateral displacement of the talus. So if you see this X-ray, what else do you need to do? Yep, all good points. Like how someone said, relocate it. Yep. Although as a radiologist, I wouldn't be touching that. Image the knee. Yep, good. So the other thing is that I would look at the lateral view for this. So there's injury to the lateral malleolus, to the medial malleolus, but there could also be a more posterior injury to the posterior aspects of the tibia. So you could have a trimalleolar fracture. But basically, I'd call orthopedics and tell them about this, and they'd probably ask to do a CT for operative planning. Yeah, call ortho, exactly. But yeah, so you need to do a knee X-ray and also look at the lateral to look at the posterior aspects of the tibia. Right, so moving on to the foot. What do you think of this? Oops, sorry, I realized I was muted. So yeah, this is a communist calcaneal fracture. I agree, Bowler's angle is flattened. Sometimes they're more subtle than this, but this is very comminuted and fragmented. What's normally the mechanism for calcaneal fractures? How do people get them? Yeah, so it's fall, and crucially, as I'm sure you understand, you have to fall and land on your feet. So what else would you be concerned about if you saw, say, this bilaterally in both calcaneum? What other injuries do you want to look for? Yes, exactly. So calcaneus fractures in themselves are, by the by, they're not particularly remarkable, but if you have them bilaterally, it implies high energy trauma. The force is transmitted upwards through the legs, the pelvis, and the spine. So you basically need to image the rest of the skeleton. Yep, very good, very good. Right, okay. What about this one? Yep, very good. So again, you want to follow the cortex around all of these. So the fibula looks okay. Tibia and medial malleolus looks okay. But when you look at the talar dome, there's an irregularity here with a lucency to the cortex. So this is a fracture of the talar dome. And again, this will be from trauma, falling and landing on your feet. There's not a huge lot more to say about this. So there's one other point I want to make, which I forgot. So there's one thing that often catches people out is pathology at the edges of the film. So when you look at, the obvious fractures will be in the middle of an X-ray. The places people tend not to look are the edges of the film. So once you've, again, coming back to my point about satisfaction of search, once you've identified one pathology in the middle of the film, you should go around the edges and look at all the other structures. So sort of sneaky fractures up here, or commonly on the lateral ankle X-ray, you can see the base of this. Do you know what this is? It's been very almost cropped off on this picture. Yeah, exactly. So this is the base of the fifth metatarsal. And this is a common place for fractures. Do you know what structure inserts into this? So it's the peroneus brevis. Yep. So, I mean, commonly people fall on their ankle and sort of invert them or evert them, and you do an ankle X-ray. But inversion injuries can also cause an avulsion fracture of the base of the fifth metatarsal. So you always need to look here. Even if there isn't a foot X-ray, you need to look at it on the ankle X-ray. I presume some of you guys are radiographers, because someone said this is always needed on a lateral ankle. Yeah, no, I agree. This is the standard view. This should be obvious, but I think sometimes there are suboptimal views, and they'll be right at the edge of the film, and this is where you miss stuff. There isn't a fracture here. Actually, I'm just illustrating the point. Right. So moving on to the foot. So we do three views of the foot. There's an AP, there's an oblique, and a lateral. And again, the principles are all the same. You want to be able to use these to assess the sort of the cortical integrity of all of these, and you want to look at the alignment of the bones. So crucially, on the AP view, this needs to line up. So this bit of the great toe metatarsal and the lateral aspects of the medial cuneiform needs to line up. Similarly, on the oblique view, this bit which I'm pointing at needs to line up. And I'll come on to why that's important later. And then we do a lateral as well. Right, okay, what do you think of this? I've given you some history here, which might help. Yep, so some of you guys have jumped in with the diagnosis. So osteomyelitis. And yes, and Jeremy has described the findings. Very good. You should. Yeah. So this is osteomyelitis. I think the history kind of gives it away, but there's lucency, which is abnormal in the great toe, distal and proximal phalanx, and there's cortical destruction. So it's hard with toes because they kind of overlap on these views, but I could probably convince you there's like a nice sharp cortex around these toes. But here it's kind of very irregular and ill-defined. So this suggests there's bony destruction. And also you can tell that there's soft tissue loss. So there's sort of lots of soft tissue around these toes. But around here, this is where the ulcer is. It's very thin soft tissue. This here on the medial aspect is almost down to the bone. And also at the tip, there's no soft tissue on the tip of that toe. It's probably almost down to the bone, which is why it's got infected. Yeah, so lots of bone destruction for amputation. Yeah, I mean, I suspect this toe is pretty infected. It probably does need to come off. Again, I'm not a surgeon. As an aside, if you're suspecting osteomyelitis, say there's someone with a big ulcer and you're suspicious, but you don't see any changes on this X-ray, it looks normal, what do you do then? Okay, so some people have said CT, some people have said MRI. So actually, in the first instance, I think it depends how high the clinical suspicion is, but normally, at least in our center, we recommend also doing a follow-up film. So even if there is osteomyelitis, the bony changes on plain film don't necessarily manifest until slightly later on. So we often say repeat the film after a week or 10 days, and sometimes you'll see early changes. So you might not see really florid bone destruction like this, but you might see a bit of periosteal reaction or some early features. In terms of CT versus MRI, CT is obviously very good at looking at bone. So you would see this bone destruction, you'd see very, very clearly on the CT. But the most sensitive test is an MRI. So MRI will show early inflammatory change and edema within the bone marrow before CT would show these sort of cortical changes here. So essentially, if you can see it on a CT, you probably see features on a plain radiograph, but the early changes of osteomyelitis seen on an MRI predates this. So if the whole foot's really infected, there are ulcers everywhere, and you're not sure which bits are infected, the orthopedic surgeons would ask for an MRI in this case. And also, if they're planning to do an operation, so say they're going to amputate this toe, they'll want to know how far the infection is, because it might be that there's loads of inflammatory change and edema sort of further back, so they'll have to resect more than they think based on this, because you don't want to take off the distal phalanx and find that the rest of the toe is also not really viable. Yeah, so in summary, do a follow-up film, or if you want an immediate answer, we do an MRI. Right, okay, so this is probably also quite easy. What's the abnormality here? Yep, very good. What about this one? If I'd known you guys would know the answers to all of these, I would have made some of these harder. Yep, very good. So this is a fracture of the base of the fifth metatarsal, which is what I was talking about earlier. So inversion injuries of the ankle, the peroneus brevis tendon is attached here. So as you stretch it, it can avulse the base of the fifth metatarsal. It's quite obvious on a foot x-ray, but sometimes you see it, like I said, on a lateral ankle x-ray as well. Right, and finally, what do you think about this? Oh, so there's a range of answers for this one. So lots of you have said Liz Frank injury. I can see why you say that, because I think this space looks a bit widened, and I think similarly here, it does look slightly wide. But actually, I think if you compare it to the other joint spaces in the midfoot, it's not particularly wide and it's not that displaced, or not displaced at all, but not particularly widened. But the rest of you have said fourth metatarsal. Yeah, so the abnormality here is a stress fracture. So the finding is that there's periosteal reaction around the shaft of the fourth metatarsal here, and there's a cortical lucency probably about here on this film, probably about here. So this is a stress fracture with surrounding periosteal reaction. So it's a healing fracture. Periosteal reaction implies that there's, well, when it comes to fractures, it implies there's healing and callus formation going on. So it's quite common in people who do lots of sports, particularly people who have started doing a lot more sports than they used to, a lot more running, that they can get stress fractures of there. It's commonly the third and fourth metatarsals. But basically anyone with this kind of history, if you see any cortical irregularity, it's like this sort of a fluffy appearance here, even without cortical lucency, just periosteal reaction would make you suspicious of a stress fracture or healing stress fracture. Right, okay, what about this one? Yeah, so firstly, there's a fracture of the medial cuneiform, so there's a lucency here. And then looking at the alignment, the first metatarsal isn't aligned with the medial cuneiform. So So yeah, you can call it I guess you can call it a fracture dislocation of the first the first metatarsal joint. But the eponymous name for this is a Lisfranc injury. So the Lisfranc ligament is in the midfoot, and any disruption of that, commonly from trauma to the midfoot, disrupts the alignment of the first and second tarso-metatarsal joints. And there's a very complex classification system for this, but I think when you're looking at these films, you just need to identify, firstly, is there a fracture? And secondly, is the midfoot alignment normal? And it's not here. And what about this one? Yeah, so this is another Lisfranc injury. This is a divergent injury. This joint space here is widened, so between the medial and middle cuneiform bones, and the normal alignment you'd expect here is that the base of the second metatarsal should align. I'll show you on my next diagram. It should align with the medial aspect of the middle cuneiform bone. So this should all line up here. So yeah, this is a Lisfranc injury. So this is just a diagram that illustrates how it's all supposed to line up on the two views, which I've nicked from Radiopedia. So on the AP, you want to look at this line, and on the oblique, you want to look at this red line here, and also this red line here. But the main thing is you want to look at all of the joint spaces in the midfoot. And as a rule of thumb, all of these spaces should look about the same. So in a young person without osteoarthritis and degenerative disease, all of these joint spaces, it's the same as the same principle as the wrist. So all the midfoot joint spaces should be about the same width. So if anything is slightly widened, then that would make you suspicious of an injury. And if anything is sort of not properly lined up, as illustrated here, that would make you suspicious of a ligamentous injury. And they're important because if you miss a Lisfranc injury, they're unstable, and they can lead to sort of arch collapse and foot deformity. So it's kind of a bad thing to miss. So that was the last thing I wanted to talk about. So in summary, I mean, you guys are all very good and you've got most of these cases. So you always need at least 2 views to exclude a fracture. You need to look at the alignment and know what the normal alignment should be. And then you follow the cortex of every bone all the way around, looking for sort of abnormal lucencies and discontinuities in the cortex, and also looking for periosteal reaction. Yeah, sorry, I forgot to mention that. Yeah, so do you mean my summary slide or the Lisfranc case? Sorry, I think I accidentally muted myself. So yes, there's a so this one there's a fracture at the base of the second metatarsal as well. Right. So oh, sorry. Okay, I think I muted myself for that bit. So yes, the Lisfranc injuries. It's all about midfoot alignment. So on the AP view, you see that the red lines basically illustrate the alignment, and So this is normal alignment. And on the oblique view, these two red lines you want to make sure are normal. And that reassures you that the alignment of the midfoot and the tarso-metatarsal joints, so between these bones and these bones, is normal, because the Lisfranc ligament connects this part of the midfoot and provides stability there. So if there's any instability or injury to it, then these will be out of alignment. And all three of these red lines kind of have to be correct, as it were. And then the other sign is looking at the joint space. So the joint space between all of the tarsal bones should be about the same. And if you're not sure, you can compare to the other side, or you compare sort of to other bits of the midfoot. So similar in principle to the bones of the wrist, you want to look at even joint spaces all of the way around. The only real exception to this is in older patients with degenerative disease, you can get asymmetric narrowing of certain joints. So, for example, the talonavicular joint and sort of the more proximal joints here commonly affected by degenerative disease. So you can see some narrowing here compared to the rest of the midfoot. But broadly speaking, these spaces should all be regular. So for Lisfranc injuries, you want to look at the alignment on both the AP and the oblique view, and you want to look at the joint spacing between the tarsal bones. Does that make sense? Cool. Okay. Yeah. So in summary, as I've said, everything needs at least two views to exclude a fracture. You want to look closely at the alignment. I've put up some examples, but I think just from looking at these, you'll eventually learn what the normal alignment should be. And then the next step in the systematic approach is to look at the cortex of every bone and follow it all the way around. So you want to look for any steps, any discontinuities, or any abnormal lucencies in the cortex. And you want to look slightly beyond the cortex to see if there's cortical thickening or periosteal reaction. So that's the sort of fluffiness or sort of ill-defined edge to the cortex. And even if you can't see a cortical step or a defect, periosteal reaction implies there's something else going on. And then once you've looked at the cortex, you want to look at the trabecular pattern of the bone, because there are more subtle fractures that can disrupt just the trabecular pattern, but maintain the normal cortical outline you would see on a plain film. And then you can move outwards, look at the soft tissue. If there's any soft tissue swelling, or if there are any joint effusions or general swelling around the joint, that makes you more suspicious of an underlying bony injury. And specific to the leg, the lower leg, we've talked about the principle of the polo mint. So between the tibia and the fibula, if you see a fracture in one, you need to image the whole of the knee to ankle joint to look for a second injury. And I didn't realize that a lot of you are radiographers, but for those of you who aren't, if the radiographers say red dot on the film and you don't know what the abnormality is, you should look closer, because there's most likely an abnormality on there. So that's everything I wanted to talk about. Most of my pictures were either from where I work or from Radiopedia. And another site that's quite useful is radiologyassistant.nl. So those are sort of two recommended sites for reading. Does anyone have any questions about anything I've talked about? Oh, sorry, what's red dot? So literally all it is when you look at the X-ray, let me find you. Let me find you an example. So say you're looking at this X-ray, it'll say which side it is, and it will literally say the words red dot in the corner. So when the radiographers who are acquiring the X-ray put it on the computer system, and they look at it and they say, oh, well, obviously there's a tibial plateau fracture there, they'll add red dot to it to draw your attention to it. So what I'm saying is, if you're working in A&E or on the ward or anywhere else, and you see an X-ray and it says red dot on it, that means there's probably an obvious abnormality that you should be seeing on it. So sometimes, I think it used to be an actual a red sticker they put on the film X-rays, but now that it's all computer-based, they usually just type red dot. Yeah, exactly. It means take a closer look at it. Yeah, it's to draw your attention to it, basically. Does anyone have any other questions?
Thanks very much for that, Joe. You've taught a lot this evening, and thanks to our viewers as well for being so interactive, because it definitely makes these sessions more educational and interesting when people get involved in the chat. And I'm sure that our participants will also agree that these cases were particularly helpful for their learning. So just to sort of reiterate with Joe's red dot, because I currently work in A&E at the moment, if you see a plain film that has a red dot on it and you can't see the abnormality, then it's worth having a chat to a senior, or maybe even having a chat to the radiographer, because there probably is an abnormality on it and you just haven't seen it. Yeah, have a sort of high threshold, or low threshold, sorry, to seek senior help when you see that on the plain film. So you should all get feedback links. They should have actually already been emailed to you, but if not, then they should pop in the next 10 minutes. I will also paste something in the chat now. So this has, the top link is a link to the feedback for Joe's presentation. The middle link is to next week's presentation. And that's going to be covering upper limb MSK. So that's going to cover the shoulder and elbow, and maybe if we have time, the forearm as well. And the bottom link is just a sign up to the webinar, any webinar series on Mind the Bleep. So we also have medicine, surgery, pediatrics, finance. There's loads of different series that you can sign up for, and that bottom link will take you to a page where you can sign up for whichever one you want. So I'll just leave another minute or so just in case there are any last minute questions for Joe. So someone's put, how can we access this lecture? So all these webinars get uploaded to Medal afterwards. So after this session finishes, this video will get saved and will get uploaded back up onto Medal. But because it's such a large file, because a 90-minute video is almost like a movie, then it should be in the next couple of days or so, but it should be accessible here as well. If you can't find it here, then it'll also go onto the Mind the Bleep YouTube channel too. So just to say again, so next Wednesday evening at 8 PM, so this time next week, Dr. June will be doing the upper limb MSK stuff, so that's shoulder and elbow and maybe forearm if we have time. And don't forget to fill out those feedback forms as well, because that's how you get your certificate, and it's also how we know how to improve these series. And there's an extra question on this week's feedback form, so it's exploring what we're going to do after this series finishes. So I think there's about 4 or 5 of them left before we've wrapped up this webinar series, because we'll have covered pretty much all the imaging modalities by that point. And it's just to gauge interest of how we can expand this further, because this webinar series has actually got quite a lot of interest from you guys, which is really good, because it shows that there's a need for radiology teaching, especially at both undergraduate and postgraduate level. So whether that be cases or going into specifics of what junior doctors might see, whether it be NG tube placement or things that are typically hard to see on X-rays, I don't know what you guys would want, which is why it's really important for you to fill out that field so we can see how we can improve this in the future and to see what you guys want. So I can't see any other questions, Joe, so thanks so much for presenting that. It was really helpful, and we'll see you guys next week.
Yeah. Well, thanks for listening, guys.
All right.